Hi, I'm Padda. I'm a medical physician. I'm an anesthesiologist. And you might wonder, what does that make it so that I would want to talk about the business of medicine? But I think it's germane. I have a background in business, have an MBA in finance, and I've been an anesthesiologist, then an interventional pain doctor. I'm also boarded in addiction and obesity. So I've had the opportunity and privilege to take care of patients that have a lot of chronic disease processes. And I've had to do it through the school of hard knocks. I've had to figure out why my patients weren't doing well, why there was a lack of durability in what we were doing in interventional pain. Even though we're really good at treating patients with pain and we can figure out what's causing their symptom, they seem to lack durability. And that's what I've spent the last 20 years of my life trying to figure out. Why is it that they lack durability? What can we do about it? And unfortunately, because physicians are burning out, because healthcare expenditures are going up, physician salaries are going down, it's left a void. And we need to figure this out because we're bankrupting the United States. About $1.3 trillion of our healthcare budget, which is 75-80% of the global budget, is associated with metabolic issues. We can fix these issues if we do this right. So I created the Measura Protocol to leverage the lifestyle treatment options for pain, to leverage the lifestyle treatment options for addiction, for obesity, for chronic disease. And it has a huge impact. It goes well outside of just pain. It goes toward health span. The main goal that we're trying to do is increase patient health span. So when we're born, we consume a little bit of resources, we get into adolescence, we become revenue neutral, and we become productive. We start producing money for the government, we start producing money for ourselves, we start becoming productive members of society. And we go into a decline, and then we have a long period of senescence. And this is the typical American. If you eat the standard American diet, this is what you can expect. 2/3 of your healthcare budget will be spent right here in the last few years of your life. You'll spend a little bit up front, but the majority of your healthcare budget will be spent here. You'll be productive somewhere in the middle of life. Now, the thing is, you can look at this another way too. We spend our whole lives to work so that we eventually retire and we're too ill to enjoy retirement. And that's another way to look at it. My goal is to improve health span for patients, is to increase their functional status and have them spend less area under the curve in senescence. If we do that, we get more productivity. We know that we can do that at least 9.2 years gain. And if you really do it right, you can get 22 years. More than half of cognitive decline is preventable by lifestyle. More than 40% of cancer is preventable by lifestyle. These aren't hokey made up numbers that somebody came out with from a textbook somewhere they wrote themselves. These are actual data points that Medicare looks at. These are data points that the Veterans Administration looks at. These aren't odd and unusual numbers. In fact, most type 2 diabetes is reversible. And I know that's heresy. I know that if I say that out loud, people go, oh, you can never reverse type 2 diabetes. And it's simply not true. You can. If the patient's still producing insulin, if they still have C-peptide, and you can control their weight, you can decompress their pancreas, you can get their diabetes to reverse. But you have to do it in the appropriate way, and you have to return their insulin sensitivity. And that's what lifestyle can do for them. So almost all patients, I don't care whether you're a psychiatrist, I don't care if you're a neurologist, I don't care if you're an endocrinologist or a primary care orthopedic surgeon, I don't care. Almost all patients that you deal with will have eventually pain symptoms in the United States. The reason why is because 93% of patients have metabolic dysfunction. And of patients that come to medical offices that seek medical care, it's almost 99%. The exception obviously is pediatrics, because only 60% of them have severe metabolic dysfunction until they get a little bit older, then it goes to 93%. But the vast majority of patients have metabolic dysfunction. And the underpinnings of metabolic dysfunction is something has gone wrong. Now, the IASP definition is extensive. It has 6 components to it. It talks about emotional experiences, sensory experiences, resembling those associated with actual or potential tissue damage. I get all that. That's not my definition. My definition is the pain is the final pathway. The body is screaming, something has gone wrong. Fix me. It's a sentinel sign. It tells you that you got to do something. And that's what we're trying to figure out. In my world, I deal with pain refugees, patients that have been rejected from practice. But I guarantee you that in the orthopedic world, it's the same. I guarantee you in the GI world, it's the same. In the primary care world, it's the same thing. Those are the patients that you don't really necessarily want to treat because they're the ones that you're perceiving as the most manipulative. And they might be because they're trying to figure things out. They're trying to figure out how to manage. And it's not just because they're addicted. They might have an addiction, and it's probably about 3 to 5% of our patients globally. But that's not the main issue. The main issue is that they're rejected from healthcare. And there's a stigma associated with pain patients. 40.7% of them can't get into healthcare. And if they have obesity, it's compounded. It's even worse. It's less likely that they're going to get adequate treatment. And these are the people that need us the most. So we've known for a long time that metabolism is part and parcel with inflammation. It's what leads to the chronic inflammatory response. It's what leads to cellular senescence and fibrosis and secondary tissue damages on the endothelial side. If you think about it, you realize very quickly that these patients that we have this impotence epidemic, that's purely a function of nitric oxide production. That's because they have too much omega-6 fatty acid and they don't produce adequate glycocalyx. And when the red cell rubs against the glycocalyx, it doesn't release nitric oxide. It's also because we sterilize their mouths with mouthwash, and the crypts that normally would have the bacteria that produce the nitric oxide are now absent. It's also because the dietary intake is so poor that it's hyper-processed, and they may not be getting the things like arginine and citrulline that might be necessary to produce nitric oxide. So those are just markers of the impotence that we see, and which is then just a marker of the chronic systemic inflammation. So it's not just the simple things that we would expect. Oh, that patient has well-defined systemic inflammation and they have this inflammatory process. It's in fact the bulk of your patients, over 93% and perhaps even 99% of the adults. It has to do with a metabolic switch. It's the alteration between glycolysis and oxidative phosphorylation. If you are predominantly a sugar burner and you accumulate adipose tissue because you're hyperinsulinemic, you're more likely to have M1 macrophage activation, and it's pro-inflammatory. If, on the other hand, you're less likely to be a sugar burner, you're burning mostly fat, you are using oxidative phosphorylation, you have more activation of M2, which is a pro-resolving macrophage. And so it's that fundamental basis. It's also, on the pro-inflammatory side, it's essentially functionally what Warburg was talking about when he talked about cancer. That's the Warburg principle, that cancers are predominantly carbohydrate burning. And if you eliminate the carbohydrates, you reduce the food for the cancer. And that's why Hitler spared him from death, because Hitler himself was worried about cancer. And he allowed Warburg to live in Nazi Germany so he could do research on the Warburg effect, which was this whole concept of cancer being a glycolytic stage. And that's why the vast majority of patients that have high consumption of carbohydrate have metabolic dysfunction, and that's why the vast majority of cancers are associated with that. It's probably about 75 to 80% of them overall, and about half of them are preventable. So it's in the fat that's the issue. And when we have normal fat, we have a balance in our metabolism. You have to realize that fat, teleologically, historically, from an evolutionary standpoint, fat was essentially a combination of fat storage, so that you could store lipids for long term, so that if you were in a stage where starvation, you could call upon those lipids and survive. But it was also where the humoral responses were. It's also where the red blood cells were produced. And that combination is called the fat body. You see that in the Drosophila. In the human, you see it differently. Obviously, the most of the blood cell formation occurs in our bone marrow, but we still have a ton of early inflammatory response that occurs in fat. That's where we get our leptins from, which is a very potent cytokine. As we get overweight, we produce more and more leptin, and our brain becomes leptin resistant. It no longer sees leptin, and normally leptin is used to tell us we're full, but it becomes leptin resistant, just like our liver cells become insulin resistant. Our brain becomes leptin resistant, and we can't tell that we're that we're stuffed, that we can't tell that we're full. And it just so happens that leptin also is a potent inflammatory cytokine. It causes a cascade of response that triggers inflammation and triggers the conversion from M1 to M2 macrophage. And it causes our visceral fat to become hyperinflamed and start leaching. And at the same time, it starts to degrade and rupture the adipocytes. So we get leaching and leaking of triglycerides, and we get leaching and leaking of all kinds of ceramide compounds and everything else that you can possibly imagine, which all leads to that inflammatory state. Now, historically, we've talked about the Mediterranean diet. We've said, oh, the Mediterranean diet's great. It's got grains in it. It's got fish in it. It has moderate carbohydrate. It must be the healthy diet. Well, it's more than that. The Mediterranean diet is a Mediterranean lifestyle. It has to do with light exposure. It has to do with mental stimulation. It has to do with social partners. In fact, it has to do with not eating also, because there's about 35 to 50 days a year in the Mediterranean countries, because they're very religious. They typically don't eat at all. They go 24-hour fasting, and sometimes they do longer fasts. So it's not just about what they do eat. It's about what they do and do not do. They do not always eat constantly. And what they do is they interact with other human beings. They get out in the sunlight. They are doing mentally stimulating activities. And what's interesting is there's a lot of smokers over there. And the smoking doesn't seem to terribly detract from their lifespan or their health span. Now, certainly I'm not advocating anybody smoke, but I'm saying it's not the major factor. The major factor is the processed food and being sedentary and isolated and avoiding the sun and eating day in and day out, morning to night, from sun up to sundown, and never depleting the glycogen out of your liver. That's a big problem. And that's not what the Mediterranean lifestyle is about. Mediterranean lifestyle is the exact opposite of that. I'm not the only one that's noticed this. Obviously, the American Heart Association, the American Diabetes Association, they all strongly support the reduction of metabolic inflammation because they know it's fundamentally tied to insulin resistance and obesity. And even further, they also know that it's lifestyle changes that contribute to 40 to 50% of the outcome for these patients. And so that's what we need to focus in on as physicians. I want to talk a little bit about the financials of this because I think it's relevant. The average orthopedic surgeon gets $1,378 for a total hip. They make $1,430 for a total knee. That includes the 90-day postoperative care. That means that they're making, if they do 1,000 cases a year, they're grossing $1.3 million, and they have to pay all their bills, and then they go home with some money. But per 1,000 cases that they operate on, they actually reject between 8,000 and 9,000 cases that they can't operate on. Why do they reject those patients? I mean, they're right there. The issue is that those patients are metabolically ill. They're sick, and they're not ready for surgery. And also, the 1,000 patients that they did operate on, they were also metabolically ill, but not as ill. Because what's interesting is after they've had their total hip or total knee replaced, half of them still have symptom. They still have pain. They still have other symptoms, and they may have replaced the load-bearing joint, and that may be moving better, and that may have normal range of motion, and it may have correct alignment. But the problem is that they now complain of other symptoms, and they're still using pain medication, and they're still socially isolated, and they're still not going back to work. And 15% of them are so bad that they complain about it constantly. And 10% of them are absolutely miserable. So about half aren't happy, 15% are just terrible. And so those are the issues that we need to deal with. We created the Measura Protocol to help our colleagues manage these patients. When you enroll a patient into Measura, we put them into a lifestyle program. We do measurement, we do biometrics, we figure out what's wrong with them, and we use a approach that uses basically ancillary services and uses non-physician caregiving to produce an outcome. And the practice makes about an extra $1,050 per patient, which is really close to what they get paid for the total hip or total knee. And for 1,000 patients, the practice ends up with about $844,000. We do it in such a way that the practice doesn't have to buy any equipment, doesn't have to pay for any of the supplies, doesn't even have to pay for the technician. We put everything in place, and we charge about 40% of that gross. The practice doesn't pay us until they've been paid. Now, if they enroll the patient into a long-term lifestyle coaching program, they'll generate about another $1.9 million in addition. And if they enroll the patients that they would have normally rejected into a lifestyle program and into metabolic testing, they'll make even more money. I've got orthopedic colleagues that don't even want to operate anymore because they make more money on ancillary service than they did in their operative cases. That's not what I recommend, but it's just interesting that this is a little bit skewed because this doesn't even require professional time. This requires ancillary service. It requires initial interaction, and then it requires lifestyle coaching, which isn't driven by the physician's time either. Now, why is this relevant? Well, it turns out that 8 to 9 years before the patient has radiologic change, they have metabolic markers that show up positive. These things show up 8 to 9 years beforehand, and they're not isolated to the joint. It's over the whole body. So even if you fix the joint, the patient's still going to have other symptoms. That's why a lot of my patients that come in with knee or hip pain or low back pain, they have pain in their neck, they have pain in their shoulder, they have pain in their wrist, they have pain everywhere. It's because they're systemically metabolically inflamed. The inflammation doesn't limit itself to one little dot area. There's a whole host of characteristics and markers that we can use to help elucidate this, to figure it out. But the problem is, these are research, and nobody in their right mind in insurance is going to pay us to look at all of these biomarkers. And frankly, it's not relevant because the patient has symptom, and we can use the symptom plus the measurable biomarkers that are approved, electrodiagnostic markers and biomarkers that are approved, to create a plan for long-term treatment. The key element, though, is the lifestyle coaching, because we want to coach the patient. We want them to get better. And that's at least 40% of healthcare delivery. You're not going to be able to just throw medications at them and tell them to get better. There's a lot of coaching that goes into this. And that's one big area that we're missing. The number one thing that happens when somebody gets diabetes is they typically get put right onto medication, and very limited time is spent on coaching them on what to eat and what not to eat. And we know that the vast majority of patients that are type 2 diabetic are reversible, but we spend so little time on coaching, and that's what we're trying to do and trying to fix in our program. The normal rate of fix is 1 chance in 167. Telling somebody to move more and eat less, that chance of success is 1 in 167. Our chances of success using our Measura protocol is about 8 out of 10. What that tells you is that our approach is not an incremental improvement. It tells you that we're using a totally different pathway, and our pathway is based off of addiction. We fundamentally believe that health and lifestyle issues and overconsumption are issues of addiction rather than you're just not moving enough, slightly, or you're just eating a little too much. It's much more than that. And it's an addiction issue, and you have to address it as an addiction. It's a processed food addiction. Most of the diseases of sarcopenia syndrome, frailty syndrome, all of those things are metabolic. And this is not new news to any of my colleagues that deal with patients postoperatively. Even if you look from a cardiac standpoint, if you look at the primary care, before the patient has diagnosable heart disease, before they get their hypertension, they have a metabolic disorder. It's upstream. And if you fix that first, they don't have any of the downstream effects. Now, the thing is, we have all kinds of tools. We've got EKGs, we've got stethoscopes, we've got ultrasounds to help diagnose the heart. But is there a tool on the metabolic side? And that's what we worked on getting. That's what we've achieved. So it extends even to psychiatry. And you would never think that psychiatric issues were predominantly metabolic, because you're supposed to give them an SSRI or you're supposed to give them anxiety drugs. But it turns out that 75% of schizophrenia is a metabolic issue. And if you fix their metabolic issue, they stop hearing voices. That's a very significant factor, because normally they're stuck on antipsychotics. And the problem is most of the psych meds actually aggravate insulin resistance. They make the patient fatter. They increase their risk of heart disease, stroke, and diabetes. And so if we can reverse all of that, perhaps we can make a bigger long-term difference for these patients. And the reality is that the average psychiatrist makes about $118.38 an hour through insurance. If they add the Measura protocol and they reverse the patient's disease, they'll add about $1,100 an hour. And that's without their professional time. That's an ancillary service. It's a 10-to-1 ratio of what they can do in their practice. So that's what we're trying to get to. That's what our long-term vision is to help patients and to help physicians take care of these patients and to fundamentally reverse disease. Physicians are really burned out, and that's a big issue. Right now, for every physician that we have out there, for every single one of them, there are 10 administrators that are riding on the donkey cart, expecting that physician to work harder. And that's why they're burned out. Let me give you some stats because I think it'll make a lot more sense. I've done a lot of research. I have an MBA in finance, and I've published a lot in the medical economic field. I did a bunch of predictive analysis pre-COVID, and it's come out to be true. It's not 100%, but it's pretty close. And the issue is that we're physicians, and we make assumptions that everybody is in the business of medicine to help the patient. And I have to tell you, that's not true. We have a lot of corporate entities in the practice of medicine, and they're not in the business of medicine to make people healthy. They're in the business of medicine because they can make a lot more money on sick patients. And the sicker the patient, the better they are. And that's antithetical to what we want as physicians. We want patients to be healthy because that's why we went to medical school. That's why we've sacrificed so hard so that we can help our patients. But that's not what our colleagues in business are thinking. And so that's what we need to get past. What's happened is that our practice cost of inflation has really gone up, but the physician updates have not. And that's led to a problem because those people with really good lobbies have been able to keep track or get above inflation. Inpatient hospitals have kept up with or gotten above inflation. We as physicians have suffered, and we're well below inflation. Now, the average specialist has lost about 8.2% in 3 years of income. And if you look at over a 10-year period, we've lost 50% of inflation-adjusted income. But yet, the inflation-adjusted healthcare expenditure, the cost of insurance, has gone up 80%. So where's the difference in this? Why is it that physician-adjusted income is down 50%, and yet healthcare expenditure is up 80%? What's going on? What's happened is the number of administrators has gone up by 3,800%. So the physician numbers have stayed exactly the same pretty much, but the number of administrators has just skyrocketed. And 3/4 of now physicians are working for these entities. And those entities don't respect the fact that we're trying to help patients. What they respect is how much net revenue are you generating per unit of time, and how busy can we make you, and how effective are you? And that's what an EHR was supposed to measure, is your effectiveness at care. And then it allows you to carry that work home at night so that you can work on it when you're not doing patient care because you got to catch up. These are massive issues, not just for primary care, but also for specialty services. Value-based healthcare was designed to put in quality measures. And we all thought, well, value-based healthcare, it's gonna deliver more value and it's gonna be better healthcare. That's not what's happened. The average physician's getting burned out. They have 57 quality measures of value-based healthcare for every single practice that they have to do. A lot of them are redundant and overlapping, and they're disparate. They're small pieces of data, and it makes physicians demoralized, and it's incredibly uncoordinated. And at the end of the day, it's a challenge for physicians just to keep their head above water because they're getting inundated with paperwork. So what we did was we created Measura. We used a Six Sigma approach to look at the processes of delivering metabolic health using lifestyle coaching, using an ancillary approach so that it wasn't physician time, combining it with value-based healthcare so we actually got all the data and it didn't overwhelm the physician. Putting it all together, we came up with Measura. And what we specifically did is we embedded it with an AI. We put an artificial intelligence into it. So it's not the AI that lives on the internet and gives you bad information. It lives on your laptop, and it basically allows you to run testing faster than you normally would. It allows you to get better results more accurately. It doesn't give you bizarre things outside of its small scope. It just allows you to run things faster. It's an extremely fast filter is basically what this AI is. It uses mathematics rather than large language learning models. It allows us to get data so that we can move along faster. If you did all of the testing that we do, it would take you 1 hour and 20 minutes and you get $400. And it would take up a lot of time, and you still have to generate a report. The way that we do it, we can do 4 or 5 sets of testing. We can get a patient done in about 20 minutes. We can do 3 patients an hour, and that effectively generates about $1,100 to $1,200 an hour for the practice. And it's done in an ancillary service method, and it automatically generates your coaching report so that can be turned over to somebody else who can then do the coaching for you. So I'll kind of go through the steps. Step 1, we put a technician in your office. That technician screens the patient. They look for age, gender, race, height, weight, BMI. They want to find out if the patient's overweight. They want to figure out what symptoms they have. If they're positive on any one of those symptoms, anxiety, depression, joint pain, nerve pain, BMI greater than 30, sarcopenic wasting, history of alcohol or cigarette abuse, hypo or hyperthyroidism, any of those symptoms, elevated blood sugar, thirst, increased hunger, dizziness, headaches, any of these, that patient highly likely has systemic metabolic inflammation. And we can go on to the next step. The reality is that almost all of your patients will qualify. It's 60% of the pediatric population, 93% of the general population, and nearly 99% of the population seeking active medical care will have at least 1 to 3 markers of systemic metabolic inflammation. And on average, our patients have between 9 to 11 different markers on review of systems, but you just have to ask them. And what's funny to me is the simple things, like we assume that patients are going to tell us the truth. Like we ask them, how tall are you? And they say, oh, I'm 5'6". And then when you actually measure them, they're 5'2.5", and they get upset. You ask them how much they weigh, and they're almost always off. Nobody overestimates their weight and nobody underestimates their height. So what we do is we actually measure it because we want to calculate. And I know that BMI is not the be-all end-all of metabolic health, but it is a good surrogate marker. And it gives me enough data combined with an abdominal girth, combined with the other biomarkers that we're going to generate, that we'll have a pretty good idea of where we're headed. And especially when you combine it with the blood testing. So this is step 1. It's an intake. It's to generate information to determine, is this patient likely to have metabolic dysfunction, and what's the likely diagnosis? It gives us an index of suspicion. We then do specific metabolic tests, and we have a metabolic panel. The way that we've set this up is our AI helps us generate which specific testing we're doing. Now, we're not doing esoteric testing. We're not doing a whole host of 50,000 biomarkers that aren't going to get paid by insurance. We've limited it to the ones that we believe are most likely to get reimbursed by the insurance and are highly correlative. So we look at things like GGT, gamma-glutamyl transferase, because that gives me a very good idea of 5-year health span and lifespan, and it gives me a correlation for hazard ratio. LDL-C doesn't do much for me. LDL-C is not even part of metabolic syndrome. HDL and a low HDL and a high triglyceride is part of metabolic syndrome. But for me, what's more important is LPIR, with the combination of LDL-P plus insulin. That's going to tell me the likelihood of inflammation and insulin resistance much more accurately than is LDL-C. I look at ApoE4 if the patient has a high likelihood of cognitive impairment. I know that half of cognitive disease can be improved by lifestyle factor, at least. And the thing is, at least 12% of that is probably liver related. And a FIB-4 score may be worthwhile if they have liver dysfunction or a history of alcohol abuse. All of that information is in our AI. It'll trigger and say, hey, this patient complains of a prior history of alcohol abuse. Maybe you should look at the FIB-4 score and let's see if this patient has fibrosis. Things like hemoglobin A1C, not really worthwhile because it underestimates insulin resistance. By the time that the hemoglobin A1C is actually going up, the insulin levels already going to have gone up, and the beta cell's not going to be able to keep up. And it's likely that if that's happened, there's enough congestion in the pancreas that the paracrine effect, the localized effect of glucagon, is going to suppress the secretion of insulin. And now the hemoglobin A1C is going to go up. But they've already been having damage from the insulin the whole time. Their hemoglobin A1C actually went down first, and then it went up. When that insulin was high before, it was causing fatty liver. It was causing fat deposition in the pancreas. And now that the pancreas is congested with fat and the liver is fatty and it's leaching liver materials and they're starting to get auto-inflammatory responses, it's too late. And those are the things that we have to reverse. So hemoglobin A1C underestimates. We want to do everything we can to get an accurate picture. 99% of these patients will end up with positive metabolic markers. In fact, it's rare that I don't see that. Most of them will end up with abnormal omega-6 to 3 fatty acid ratios. And it's the abnormal omega-6, which is vegetable oil, that destroys the lipid raft, that then destroys the ability of the insulin receptor to translocate and makes the cell insulin resistant. So it's those factors that we want to look at. And I know there's conjecture in the literature about vitamin D. But the reality is, it's not just vitamin D. You want to have a decent vitamin D, but you also want to have sun exposure, and you want to have vitamin D be active. It's more than just vitamin D. Vitamin D itself alone is not going to do it. It's the cycling of nutrition and the sun exposure and the exposure to other human beings that makes a difference. It's very hard to do true studies on metabolism when everybody has so many chronic disease states. So we get to the next step. We get the blood testing back. We get the laboratory testing back, and then we'll do a series of metabolic tests that are part of the Measura. Now, some patients will need an ANS test. Some patients will need an arterial stiffness test. Some patients will need an RQ because their thyroid hormone was normal, their TSH was normal, but they still feel fatigued. Their T3, free T3 was normal, and their TSH is normal. But it turns out that their BMR, basal metabolic rate, is dropped by 40-50%. Those patients you can't get to that diagnosis without a metabolic card. Some of these patients are going to have vestibular imbalance, and if they fall, about half of them are going to break something. So we need to get ahead of that. And this is really important on these patients that have sarcopenic wasting or they have excessive fat. They're all at risk because they're high risk for senescence and they're high risk for osteoporosis. So these are the tests that we run, and our technician runs them in your office. We do all of the testing, we provide the equipment, we run it through our AI, and it generates a report. And this is done as an ancillary service. It's not the physician having to do this. We coach and counsel the patient while we're doing this testing. So it's not totally separate. We do this while we're doing the testing. The next step is, once we get the report back, you have an option. You can discuss it with the patient, which a lot of physicians do, and there's a billing code for that. But we also will then engage the patient into a lifestyle coach, usually by telemed. We'll use a code 98960, which is education and training for patient self-management by a qualified non-physician healthcare professional using a standardized curriculum. Our AI will have designed that standardized curriculum for that patient. So this is not the physician having to do this. This is a non-physician, and it's paired inside of our remote patient monitoring, remote therapeutic monitoring, and chronic care management codes. So that's where we are able to do the long-term coaching. And there's 26 units of this per year. So this is separate than RPM and RTM and CCM coaching. This is completely separate. Now, what's interesting is there's a bunch of data that you've collected along the way. You've collected all of the patient's index of suspicion. You've collected all of these other diagnostic codes, and you've collected a bunch of data on their blood testing, and now you have all this electrodiagnostic information. All of that gets entered into your electronic record, because now when you have to do your MIPS scoring, it's all there. It allows you to have value-based care and be very robust, and fulfills all of those 57 disparate characteristics and categories that you would have to personally do, because you're going to retest this again at 6 months and a year. And not all the blood testing, obviously, because that really doesn't necessarily change on the genetics, but some of the other metabolic markers do change. A organized approach to this is done, and that's what allows us to close the quality loop. And that's why our patients do well. The normal chance of losing weight is 1 in 167. The chances in our clinic, because we use an addiction-based process, is 8 out of 10. What we've done is we're using residual ancillary income. So it's not the professional service that's being delivered. It's a residual income that's being delivered through ancillary services. So again, it's 4 steps. Physicians cannot make money on blood testing, but that's where the value-based healthcare kicks in. That's where the index of suspicion is generated. All of our blood tests go to independent labs. We don't allow anything out of network lab billing, and we don't allow them to force patients to pay copays. If a patient has in-network lab billing, usually the copays are minimal. And if the patient has financial hardship, we tell the lab, hey, look, the patient has financial hardship and we don't want you billing that patient. And most of the time, they won't bill the patient because the patient has hardship. Our practice can't make money on step 1 and 2. The practice does make money when we do the Measura testing. It's about $1,050 per patient. 1,000 patients annually in their practice generates about $844,000 for the practice. Typically, about 60% of that stays with the practice, and they pay us after they've been paid. 40% comes to us for running the service, getting the equipment, doing everything else. The majority of the money obviously stays with the practice. If the practice decides to do lifestyle coaching with a remote patient monitoring, we integrate them in with an RPM company. It's usually a 50-50 split. Typically per 1,000 patients, it's a gross of about 1.9 million. Again, this is not driven by physician service. It's driven by an ancillary service, and it's driven by non-physician healthcare. The most common questions: what percentage of patients qualify? 93% in the general pool, 99% of the patients that have symptoms that are showing up in your office, and usually symptoms are pretty diffuse. About this AI, it only lives on your laptop. When it needs to be upgraded, we have to come to site to upgrade it. We own the equipment, we maintain the AI, we own all of the equipment that you do your Measura testing with. So if something breaks, it's our responsibility, we replace it. If something happens to the equipment and you have a catastrophic fire, then that's different. And we want you to name us as an additionally insured, because if there's a catastrophic loss and it's a theft or a fire, then that's outside of our control. But if it's unique to the piece of equipment and something's damaged, then we take care of that. We maintain a firewall between our AI and your health record system. We don't allow the two to connect. We don't want the AI to be on the internet. So we transfer those files by PDF so that there's no AI connection to the EHR. Our technician is in your office. Their job is to screen these patients, and their point is to get the height, the weight, the blood pressure, and to do the screening. It literally takes our staff about 3.5 to 5 minutes to do the initial screening to figure out if the patient is appropriate category. They will help you get the data into your record, and that'll allow you to improve your MIP score. Can you do this on HMO patients? The answer is probably not a good idea, because HMO specifically is a global payment system. So if you do this on HMO and the patient's already enrolled, you're going to take money out of one pocket and put it in the other pocket and then pay 40%. I wouldn't recommend that. If the patient is going on to HMO, I would recommend you analyze them first, because it'll dramatically change your HEDA score. And if your HEDA score is higher because you've diagnosed the correct pieces of information, then it's more likely that your monthly payment under capitation will be a little bit higher. What you're doing is you're creating a risk-adjusted scoring system. Can you do this on ACO? Absolutely. This will actually improve your ACO scoring, because your risk-adjusted scoring improves because the patients are getting better. They're losing weight. They're becoming non-diabetic. You're taking them off of their medication. You're deprescribing them. Their blood pressure's getting better. That's what medicine's about. It's about making that patient better. Can you cancel? Of course, you can cancel at any moment. Just tell us that you're not interested, and that's fine. How do you pay us? You pay us 30 days after you've been paid. You don't pay us before. You get paid first. We do an audit trail. 30 days later, we issue a bill, and you just pay us once a month. We're not in this to chase people down. And what we want to do is we want to provide an amazing service, and we want to help you help your patients. At the end of the day, you make money because it's ancillary service and it's not your professional time. The point is not to make a bigger hassle for this. The point is to get these patients better. We want to make sure that our incentive is aligned with your incentive, which is aligned with the governmental incentive of helping the patient, which is inherently aligned with what the patient wants. Timeline on implementation. Right now, as of summer, fall of 2024, it's taking us about 18 weeks to get implemented in somebody's practice. I think that timeline will change over time, but that's what it is currently. Just reach out to us and we can chat about implementation timelines. The responsibilities that you have in this is to help us identify somebody who's a good collector, because we're going to pay for them. If you already know somebody in your area or somebody that you want to use, that would be perfect. But that person that does the collections is going to get trained in lifestyle coaching. So they not only have to be able to collect blood or urine or XYZ or their buccal sample, but they also need to have the wherewithal to understand lifestyle medicine. They have to live, breathe, and eat it. And so it's going to take a little bit. It's not the average Joe that comes in. So we end up paying our collectors about $25 an hour. And with bonus plans and things like that, they end up making about $60,000 to $90,000 a year. It's a combination of responsibility, and it's a combination of payment that goes hand in hand. The better the collector, the better off we all are. The key element, though, is we wanted to do this as an ancillary service, so it didn't consume the professional time of the physician themselves. So if you have any questions, reach out to me. Our real advantage is obviously that we've been able to create a lifestyle coaching program that pays and doesn't consume your time. It's ancillary service. And then the long-term treatment really helps the patient because it's a addiction protocol rather than a general protocol. It's not just about moving more and eating less. There's a lot more that goes into it. And we've been able to get to that because it's taken us about 20 years. 9 months ago, 2023, we couldn't even do this because our AI didn't work very well. Our AI has had just an incredible improvement. None of the testing that we do is odd. It's nothing special. What it is the AI has allowed us to run it faster and run it in a complementary fashion and run it together. So we get much better data and much better outcome much faster than anybody else can. If you have any questions, please reach out to me. I'd love to chat. Thanks so much.